sports medicine project myself, one squeaky chair. Hope you can't hear it. But most importantly, welcome to my co-host, Kelly Kortic. How you doing, Kelly?
I'm good. That was very nice. I don't know if it was sarcastic or not.
No, it's true. It's the most important. People, they don't come to listen to me. I mean, podiatrists, we've only got a little bit to talk about, but with you physios, you can talk about anything. Everything's in your scope.
And how fitting for today's guest, which
Yeah.
is another area of physio that we haven't really spoken about heaps on the podcast.
Not at all.
Unfortunately, I wasn't here for this podcast guest talk because I was away over the weekend, but I'm so excited to listen back on it. It's going to be the first thing that I do tomorrow morning. I think I'm going to get up, go for a walk, put my AirPods in and learn all about women's health physiotherapy.
Nice. Yeah. We had Daley on the podcast this week, and this is part one that you're listening to now. And unfortunately Kelly wasn't here, but I got to record the whole thing, which was awesome. And it was one of the only episodes where I went in and I knew the least amount about this topic. So when we have people talking about tendons and bones and orthoses, I know a little bit about that, but women's health physiotherapy, which is so inclusive of so much. I'm trying not to stereotype at all, but I'm assuming if you're a male or you don't see any women's health patients, you think, this episode's probably not for me and I'm not going to get much out of it. But I can guarantee you need to listen to this episode, because as a health professional, being a good health professional is knowing about what other professions do. And we talk about screening and when to send patients over and that kind of thing. But
yeah, that's what I was thinking, being a good identifier, because there will be times when you have a woman in the gym doing heavy deadlifts and maybe she might be comfortable enough around you to voice her concerns around incontinence, and that's the perfect opportunity for you to be able to refer to a women's health physiotherapist.
Yeah, one of the meta-analyses we talk about in the podcast is a 25.9% prevalence in all sport for female athletes with urinary incontinence, and up to 75.6% in volleyball of all female volleyball players. That is huge. 3 out of 4. And she was saying, I hope I get this stat right, but 2 out of 3 women will have incontinence, which is not normal postpartum.
I think there's such a high percentage that have it with pre-pregnancy.
During pregnancy?
No, before that even if you haven't
prior,
had kids,
okay, yeah.
I don't know if you guys touched on that or not, but yeah, it's super common in women.
Yeah, we touched on a lot. She was great speaker, and we're going to have the video on here. She had the models out and the diagrams, which was awesome. We ended up speaking for over an hour, which I love when we're able to go longer, because there's always things to talk about. But
Blake sent me a funny text message after the podcast was recorded, and it made me laugh.
Yeah, I just wish I
was just sitting on the beach reading my book. I got this text message from Blake. I look at it and said, man, I wish I knew what a prolapse was before I went in for that podcast.
No, it wasn't. I wish I knew more about it. I had tried my hardest to learn about it. I'd read some studies, but I just wasn't. Unfortunately, I wasn't across it enough to be able to. And I think I did a pretty good job, but we'll see. Luckily,
sorry to throw you in there.
No, that's okay. I'm very happy to take. Yeah, I didn't know much about it at all. And I knew as much as what I learned from you, from other people I follow on Instagram as well. But otherwise, and Katie's one of those people, but otherwise it was just what I'd gone out to learn. And it's hard because you're not implementing this stuff. If I'm learning about an Achilles tendon, it's very likely I'm going to implement what I learn 5 times the next day. Whereas women's health stuff, I'm probably going to get deregistered if I'm a podiatrist giving advice on that. But the screening questions were really important, especially around running and urinary incontinence for runners postpartum. That was one thing that I think that I'm going to start to talk about and ask about. And we kind of drew the similarity. It'd be interesting to get your opinion and see how you asked that question. But we were talking about initially, it can be sometimes hard for males to ask younger females if they have a regular menstrual cycle, if we're possibly screening for red S or low energy availability. And we were kind of saying it's similar when you're asking about that, especially if you're in another profession. What the fuck's this podiatrist asking these kind of questions? That's really weird. But posturing it from the point of view of, where and how we could possibly send on to someone to help with that, because it's really common, and we see lots of runners. Like, I'm thinking about it now. I don't know about, do you ask these questions?
I wouldn't ask it on the initial appointment, I don't think.
Yeah.
I just don't. I think there's so much to go. Well, I don't know. Maybe that's
you're right. It wasn't, and we talk about it in the context of not the first person as they sit down saying, "Great, where is your pain?" Also, does this happen when you run? It's not like that, but slowly speaking about that, and I was saying as well, important in the gym. Like, if you're giving someone a gym program, or you're going into the gym, like possibly having that discussion prior, and it's not a really invasive question, just posturing it from and I'm not going to spoil it, you have to listen to the podcast, but posturing from the point of view of, you're trying to help and there's people that you can see.
I would probably tend to bring it up a little bit more, so once we've moved on from that initial consult and we're in the gym starting to do some lifting or some plyometrics, jumping, that's kind of when it tends to become a little bit more sort of relevant to the situation. Yeah,
good. Otherwise, anything exciting happened in your week? You had a pretty good week. You were hanging out with Nikki, running around, which is fun. Yeah,
did some running around in Coffs Harbour. Got to explore the mid-north coast, which was really fun. And feeling good going into the week.
Feeling ready and recharged.
How was your week?
Yeah, it was good. The weekend was good, as much as I do love to spend time with you. But I just had the whole weekend to rearrange the house, which was cool. So made myself a little cool office. But one of the cool things, and we apologise for not releasing a podcast last week. We had recorded a full hour, and it was a good one. Over an hour. Good debate. We were into each other.
We were really into each other.
And then we were using the double mic, and something happened with my Mac said it was full, so it stopped, and then didn't have anywhere to save it. So we only got like the last 5 minutes, not the first.
That's the first
hour and something.
79 podcast episodes.
Yeah.
That was the first one that we did not have after we finished it, and we contemplated re-recording it, but we just felt like the authenticity just wouldn't be there. So apologies.
One of the things I learnt this weekend was listening back to the podcast with Ebony Rio, and we always talk about what has to change, or what does change when someone gets better with a tendinopathy, and talking about, and I'm going to try not to butcher it, this is the first time that I've said it because I was saying it out loud. I was in the house this weekend, but the ion channels within our tendons, and we have them in tendons, bone and cartilage, they detect chemical change or mechanical change. Now, those ion channels send a signal to the afferent nerves, which then send it to the spinal cord, which then send it to the brain. So one of the things, and this is a theory that Ebony was saying, was that they have shown that those ion channels can be replaced. So they can change, and because they can detect a noxious stimuli and basically be responsible for reproducing pain up to the spinal cord and the brain, it's possibly that as things don't change structurally within the soft tissue, those ion channels could change, as in new ones could come through, and they're perhaps not as sensitive and not sending as much as a stimulus. I'm probably butchered that, but I thought that was pretty cool, because that's possibly maybe what, in combination with other things, but that is what could be changes, and then that would make sense to why the structure doesn't change.
I can't remember if this was in the podcast episode that we didn't record, or if it was the one before that, but that, what Blake just said, was a really good example of how us as clinicians and physios and health therapists, health professionals, need to have a really good, solid foundation of knowledge to then be able to simplify and explain things well, and have a good understanding about why we do what we do and what the impact it's going to have. So what Blake just said, that's not something that I'm sure he would ever explain to patients, or it wouldn't really necessarily be relevant to ever explain to patients, but I think it's really important for us to have a good understanding of some of the pathophysiologies, or all of the pathophysiologies of the conditions that we treat, because I do think it helps us be able to make better decisions. Yeah,
definitely. I mean, I simplify. I do say a version of that where I talk about their tissue and the things that are responsible for detecting a stimulus, they can change. Like, I'll say that to patients, and I'll say that's why it can be up and down at times, and that why it can take a longer while for things to get better if it's been sore for a long time and been sensitive for a long time. But I think you're right. If you can simplify, which is always easier said than done, but if you can simplify those those really complex topics to some degree. I mean, you're saying a version of the right thing, and I think it's going to help patients be able to understand what's going on for them and also understand why these things are happening. And this is in the context of saying, I think you asked the question to Ebony, why do tendons warm up and feel better when there is still, in quotation marks, pathology there? And that could be one of the reasons where those ion channels open up and they can't take any more, so they can't deliver any more noxious stimuli, and that makes them feel better. But then the next day, when they've kind of reset, you've got lots of discomfort and pain. But we've got a thing coming about it on the Instagram, which is good. So let's leave it there. Very short intro, but you're going to love this episode with Katie Daley, and we'll talk to you guys next week. Just when you thought it was done, one thing that we forgot to mention is our Patreon sign up, which will be in our show notes. We've had a couple of people sign up over the week, which is good, very slowly growing. But what we've decided to, which I think is really cool, every month we're going to jump on and do a live case study with images, rehab, the progression, the prognosis, what we did, follow-ups, that kind of thing. And I'm pretty excited for that. I think it'll be really good to have people be able to at least see how, I guess, the process of the thinking, and then be able to ask questions in real time. And then we'll also put that up there as well on the Patreon. So link in the show notes. It is $6.50 a month if you can justify. I heard someone say it's worth a cucumber a month. So if you can justify, I think it's 3 case studies plus a live case study and some other video recordings. We'll see you guys over there. Have a cracking week. Welcome back, lovely listeners. Hope you are all very well. I hope you would be. I mean, you're listening to this podcast. You're very excited for this very educational, informative show that we have today. Now we have the very, very excited Daley coming on to talk about everything women's health physio. And I'm super excited, only because certainly as a podiatrist, but also as a male, this topic hasn't really been discussed much, in my case, at university levels, or certainly not in friend groups and typical social media kind of world. So I'm very excited to learn about this. It is just me today. Kelly's unfortunately away, but wanted to welcome Caitlin. Thank you so much for coming on.
Yeah, thanks for having me on. I'm really excited.
Yeah, especially on a Saturday as well. I mean, I know you love this topic and you're very passionate about it, but giving up your time on a Saturday, you must very much like it.
Oh, look, that's okay. I've been at Inflatable World this morning and dealing with kids and icy poles and cupcakes. So
this should be a breeze then.
Yeah, this is like my me time. So let's do it.
Beautiful. Now, but before we get started, I did do a little bit of snooping before we started this episode. Can you tell us kind of your journey from a student to where you are now? So you're a physiotherapist, studied at the lovely and great University of Newcastle. You've got a postgraduate certification in pelvic floor physio in 2019 from University of Melbourne. And I saw this from your LinkedIn profile, certified yoga teacher with over 200 hours. And I know you're very fit and healthy and strong, I see from your Instagram. Is that right? That's right?
Yeah.
Yeah,
you're doing well. And then last year I did the University of South Australia. They have a pelvic organ prolapse certificate. So now I'm qualified to fit pessary devices for prolapse.
Wow, that's a lot of qualifications and a lot of study.
That's awesome. It is. Yeah, it's kind of like 2 different ways you can go with specializing as a physio to then get into women's health or pelvic health.
Yeah.
One is sort of through the university level and masters and things like that. And the other one's through a group called the Women's Health Training Associate. And they run like level 1 women's health, level 2, and then you progress like that.
All the way through. Okay. Is it similar to, like, for people listening to this that may want to follow that pathway, is it similar to like doing sports physiotherapy or sports podiatry, where you go through a couple of years and you do it through university and it might take 3 or 4? Is that right?
Yeah, so it's a really topical question, because the APA, so the Australian Physio Association, has just released like a career pathway.
Cool.
That's to streamline people coming out of uni that want to go into pelvic health, making sure that everyone's getting the same benchmarks, and so that the people calling themselves women's health physios do have adequate training and experience to be getting that title and seeing those types of patients. So it's all going to be a lot more standardized soon, because they recognize that it wasn't very, I suppose with doctors, there's those really clear levels, and with particularly pelvic health, it was getting a bit blurry, I think. So, yeah, like long story short, I think the new pathway is a couple of years of both experience in the clinic and meeting these benchmarks with study, whether you've gone through the APA pathway or through the university level, and then you can apply for titling, and then you can apply for like specialization after that.
Yeah. Okay. Interesting.
Yeah, it's a bit of a process.
Yeah. As they always are. Now,
Yeah.
with the topic of women's health, like that is like so broad, and I'm relating it back to my profession. I guess any profession where you say, yep, this person is a podiatrist, and there's so much underneath. Same with physio, same as if someone's like an engineer. There's all these different levels.
Yeah.
Like, what is women's health really, or how would you describe it? And are there subcategories, or what is it?
Yeah, that is like such a broad question, but I like it. I think as a physio, to be a women's health physio, you're talking about you're a physio that's interested in treating women throughout their life stages and conditions that affect women throughout their life stages, and usually that's relevant to or concerning their pelvic health conditions, which is urinary incontinence, prolapse, pelvic pain conditions, fecal incontinence, etc., like pregnancy, postpartum. But you also get women's health physios that are trained in treating like breast cancer, lymphedema. And so it's quite broad. But for me, I'm definitely more pelvic health. Yeah.
Yeah. And is it growing and increasing? Like, I just finished reading Stacey Sims' book, the new one that just came out, and is it Raw? No, that was her old one. One of her books is just about like perimenopause and postmenopause, and she was saying a little bit in the history that the just women's health in general had kind of been put to the side, and not many people, especially doctors, really knew much about it. Like, is the field growing and the number of practitioners around it growing as well? And I guess people's knowledge growing about it, do you think?
I think there's been a huge surge in interest in it, probably in the last like 10, 15 years, in terms of physios wanting to then train in this specialty. So that's been really cool. I'd say there's still those gaps, as you expect with research, because everything lags behind in, going from a time where the information we're referring to from research wasn't even done on females. To like now we've got that, the research coming, but it's all, quite low quality and stuff like that. And so, yeah, like it's definitely coming along, but there's still in the research quite a bit that we are uncertain of. So we don't have the answers.
Those studies where they look at, they'll have like, we included 60 people and these are the outcomes, and you look at the people included and it was like 20 to 22-year-old males at a college or something like that. It's like, that may not be as
not very generalizable.
So what is your kind of origin story? Like, how did you get into this, and was there a moment or an experience, or what kind of set you on the path to this?
So I was going through uni, as you said, Newcastle University. I remember I got to third year and I was sitting in one of the lecture halls feeling kind of a little bit deflated. I kind of got through those anatomy topics and it had been pretty content heavy. Obviously they teach you sort of everything. So we'd done neuro, we'd done cardiopulmonary. We were starting to really dive into, musculoskeletal stuff. And we had this lecturer, Pauline Shirelli, come in, and she was pelvic floor, women's health, and I just remember that moment, and I was just like, this is it. Like, there's nothing better, It was like, these are the coolest muscles in the whole body. It was just a massive nerdy moment, and I'm like sitting there having these thoughts, and my friends walked out and they weren't inspired at all, and I'm there like jumping up and down, thinking like, how funny was that lecturer? Like, how great was it? And they're all just like, So that was my moment. And then I just, I was lucky enough to get a placement in fourth year at the John Hunter in the sort of obstetric gynae placement, and that was amazing. And I just didn't want it to end. And then I did my first female pelvic floor workshop as I was coming to the end of my degree, and that meant I was qualified to do exams, internal exams, and I landed my new grad job at a clinic that specialised in pelvic health. And sort of from there, it's been interesting because I went back to the musculoskeletal world for a bit to kind of get my clinical reasoning at a broader, like up to scratch on a broader scale. But I really always wanted to come back to pelvic health. And whenever I had a women's health, pelvic health client, I would light up, that was the best day. So then I approached the business I was working for and I said, like, this is what I really want to do. And they weren't able to, they didn't want to offer like any PD to support me getting upskilled and stuff like that. So I ended up leaving that job, and that's when I went and did the Uni of Melbourne postgrad. And started my own business, and it's kind of gone from there.
Yeah. So what are you doing? Like, what's an average week look like for you now? I know you do a fair amount of training, which is awesome. Lovely family work as well. I'm sure it would be pretty hectic, but what does it look like, kind of clinical life?
Yes. So like my husband owns 2 physio practices. And so he's Monday to Friday, he's really, really busy. Last year I was working 2 days a week for myself, as well as, teaching yoga and teaching a bunch of movement classes at the gym and stuff. We had our daughter in daycare 3 days a week, and everything was pretty hectic. And I think it just got to a point toward the end of my pregnancy with my second that I just felt like, no, this is a bit too much at this point. We had renovations going on at home as well. So closed my business down and took like an early maternity leave in October last year. So I've been on mat leave. I had our second bub in February.
Wow, congratulations, by the way. I think I've said that yet. Yeah, it's exciting.
Yeah. And and I'm just starting to dabble with like reintroducing work in the next couple of months, which is just going to be a day a week that I'll be working for someone else.
Awesome. So talking, and again, I guess they're pretty broad questions, but the myths or the common myths that you hear, and that can be from clinicians or patients or that you just see in the kind of social sphere, the biggest myths around kind of pregnancy and pelvic health and kind of considerations postpartum, because I imagine very much on the social sphere of Instagram and Twitter and LinkedIn and things, there's lots of people that probably have an opinion when they maybe don't have all the experience to have that opinion, and this is probably one of those areas where that does happen. So what would you kind of say to that? What ones do you hear?
Man, I think with social media, it kind of swings in different ways, like sometimes social media, you've got people doing extreme things really early postpartum, and that then is really negatively viewed in social media. And so then when we swing the other way, and then we're telling women not to do anything in their early postpartum, and I don't think we need to be at either extreme. So I think I'll answer the question about the common myths, but that's just something I've really noticed. It's like we're not really seeing just like the middle ground with postpartum rehab. We're telling women it's all or it's nothing, or all is terrible and nothing is right. But I really think it's just super variable and individual as well, what we should be doing postpartum. Probably the most common myths I would hear is that urinary incontinence is normal after you've had a baby. You've probably heard that one, maybe.
Yeah, I've heard that.
So the Australian Incontinence Foundation came out and said they had a really great like little logo slogan thing that was like, incontinence is common, but it's not normal. So it should never be considered, like leaking urine involuntarily should never be considered normal.
And is that all? Is that just during physical activity, or that's all the time?
That's at all. So with incontinence, we break it down into during activity or during rises in abdominal pressure, so your coughs and sneezes, that sort of stuff. So that's called stress incontinence. And then you've got your urge incontinence, so your overactive bladder. So that's that can be happening, and when you leak urine and the bladder's contracting too much, it's called overactive bladder wet. and you can have urgency without leakage, overactive bladder, dry.
Yeah.
And then some unlucky people have both leakage when they're doing activities and this urgency that causes them to leak, and that's called mixed incontinence.
Yeah. Okay. And talking about like pregnancy and this, and I know I haven't had people ask me this directly, but I certainly know that Kelly has, talking about how active you can be up until, you give birth. What are the general recommendation? Is it really individualized, or is it if someone feels comfortable, or it's like, no, it's at this point is when you probably shouldn't be, or is there scans or kind of objective measures that we know?
Yeah. So there are guidelines. Yeah. Like basically, to summarize them all up, 150 minutes to 300 minutes of moderate intensity exercise per week, 2 strength training days. So that's, similar for just general adults, right? But that's for people with a low risk, what's considered a low risk pregnancy, and for people that have been exercising before.
Yeah.
And the guidelines say, if you haven't been exercising before, you want to gradually build up to about 25 minutes each day of low to moderate intensity exercise if you're pregnant. Yeah.
And how does that work off like the time frames as well between trimesters and things like that?
Yeah. So the recommendation is to exercise all throughout pregnancy.
Yeah.
There are little, caveats where it's like avoid, high impact or exercises where you could possibly fall due to after 16 weeks due to creating trauma on your belly. Obviously, you can't scuba dive or skydive or those kinds of things. Hot yoga and extreme kind of temperatures you've got to be careful of. But otherwise, exercise is really acknowledged now in pregnancy as something that can improve outcomes with women's birth, with the health of their baby, with their own health. So I think I read a stat that sort of said it's like for women doing pelvic floor exercises as well during their pregnancy, it was like a 69% less likely to have incontinence at the end of their pregnancy.
Wow.
And a third less likely to have it in that first 3 months postpartum.
And you surely just had to be reading my mind. In my mind, I'm thinking to myself, I wanted to ask you, not to say that it would be required, but do you think people would get benefit, and probably all people, like during pregnancy and after pregnancy, seeing a women's health physio, even if it's only a couple of sessions?
Like 100%, like 110%, because it's not just pelvic floor exercises, but it's like it's getting advice and guidance around general exercise. So especially if your pregnancy isn't just straightforward low risk, you might really need things adjusted and adapted for you.
Yeah.
If you've had babies before, that area has stretched in the abdominal area, so you can really benefit from checking in with that and getting individualized core exercises. But probably the biggest area that women's health physios are having a role now is actually in birth preparation. So women getting assessed before they go to potentially have a vaginal childbirth and seeing whether their pelvic floor is overactive, because there's new research coming now that suggests that actually could be kind of a barrier to that second stage of labor where the pelvic floor needs to open to allow the baby to come through.
Wow, that would have huge implications. Like if you're able to, and I'm like assuming you're assessing this, and then is there ways to change or influence that? Is that with exercise and movement or education, or what do they do? Oh no, did we cut out?
Sorry, I think our internet's jumping around a little bit. Give me a sec. We're good. Okay. We're back. Sorry, can you just repeat that last bit?
Yeah, I was just saying like the implications for that are huge. Is it possible to... Wait, there we go. Is that back?
Are we good?
Yeah, I think so. I can see like the little side. Good. The implications for that I imagine a huge, like, does that mean that you're able to, like, how would you be able to influence, or are you able to influence that if you identify that, or is something that happened at the hospital, or that's something that you and your patients would do?
Yeah, definitely. I think it's all part of identifying like a woman's risks of having issues when she's in childbirth, whether that's, increasing her risk of having a prolapse once she's had the baby, or increased risk of having, muscle tears through her pelvic floor. So yeah, we can identify it in the clinic. Like we're trained to do that with digital assessments, but also ultrasound, transperineal ultrasound.
Mm-hmm.
And we can treat it to a degree. We can definitely do muscle retraining, breathing retraining, pelvic floor muscle down training.
Yeah. Wow.
And if that gets to a point where like the woman has that voluntary control to be able to relax and drop that tone, then, she's in a better position to have a vaginal birth. But I've certainly had a patient before that was a power lifter, very overactive through her pelvic floor. And in her pregnancy was showing on her scans to be having quite a big baby and large head circumference. And it was her first time having a baby. So all of these things were pointing towards she was more likely to potentially have an obstructed second stage. And she ended up choosing to have a cesarean section.
Yeah. Wow. Would you say, like, what is the most common result of pregnancy? Like, is it urinary incontinence? Like, what is and that would be, and then following that, is that the most common thing that you see as well?
It's tricky. Yeah, that question, like 2/3 of women after they've had a baby will have urinary incontinence. Like that's the stat. In the early, so we're talking the first 3 months. So early on, urinary incontinence is definitely more common. But then in the lifetime of a woman, 1 in 2 will have a prolapse if they've had a vaginal delivery.
Yeah.
So 50% will have vaginal prolapse. Yeah. Or pelvic organ prolapse, sorry. If they've had a baby vaginally. So those 2 conditions probably the most common. But again, you see them at peak at different times.
And do we have a good understanding of their management? Like how do you, and I know it's almost impossible to answer this question, like, hey, please give me an exact approach to how they're managed, but genuinely are there like some principles and kind of common threads that you would use to manage those 2 conditions?
Yeah. I mean, we always start with like a really thorough assessment because often the 2 conditions can exist at the same time.
Yeah.
Or they can be influencing each other. We always start with like a really thorough assessment, and we really look at like degree of bother too, because a lot of these pelvic floor dysfunctions, as we call them, incontinence, prolapse, like there's no mortality, more or less. It's morbidity, it's quality of life. So we have to, when deciding what sort of treatments to do, we have to see what's most important to the patient. What do they want to do about it? Some people just want to put a continence pad in and they're not particularly bothered as long as they know it's not going to get worse, which sometimes it can with age. But anyway, so for instance, incontinence, the treatment, the first line treatment, so grade A level 1 evidence is to have a pelvic floor physiotherapy.
Yeah.
For incontinence. So that comes before medication. It comes before injections. It comes before sling surgeries and things like that.
And is that that's generally a pretty good outcome? Like most people respond well to that and don't need to go further down the line?
Yeah. The trick is it's 12 weeks. 12 or 16, I can't remember exactly. It's 12 to 16 weeks minimum of intensive individualized pelvic floor physiotherapy.
Yeah.
So in studies where they have got the women to do that and they've monitored, whether they're doing it with training logs, outcomes are fantastic. The trickiest thing with pelvic floor muscle training is getting people to do it and do it consistently.
What does it consist of? Like for someone that has no idea what that is and they're just thinking like, what is the pelvic floor and what muscles are you using? And because I think, I don't know if this is, you find this, and it'd be funny because I know we'd just be in vastly different circles and perspectives, because certainly in the podiatry sphere, people don't talk about this at all, and especially, and that's what Kelly was saying this week. Like, it's not in musculoskeletal physio, it's probably not talked about that often, depending if you're speaking to someone who specializes in it. And we know like specific muscle activation in, you know, knee conditions and foot conditions and back conditions haven't really shown to be that effective. They used to be 20 years ago, but now the research says you can basically do anything. So when it comes to the pelvic floor stuff, it really is specific muscle activation that helps. Is that right? Like, is that,
yeah, it's the same. There's been like a study on it by Kari Bow in 2005, I'm pretty sure, that was titled like, is general physical activity good or bad for the pelvic floor?
Yeah.
AKA, like, can you not just isolate these muscles with these squeeze and lifts? Can you just be physically active and still have a healthy pelvic floor?
Yeah.
And also on the flip side of that, like, if you're sedentary, do you have a worse pelvic floor?
Yeah.
And just examining like that relationship. What she found was that you do need to individually train the pelvic floor muscles.
Yeah.
People that are physically active tended to have healthier tissue in their pelvic floor, but they weren't necessarily always continent, which is really interesting. So they might have shown thicker muscle, but they weren't necessarily activating it appropriately to keep their bladder up to not leak with impact.
This sounds exactly like everything else in the body. It's like, yeah, these muscles are really strong and resilient, but it didn't actually work as well as we thought it would. But yeah, sorry to go back to that question. What is the pelvic floor and muscles? And yeah, good. Okay. Now, if you are, most of you, I think 95% of you listen to audio. This also goes on our YouTube and it's recorded, so we'll be posting this, so we'll be able to see this lovely anatomy. I was about to say foot model. That's what I think about, but anatomy model. Like how it's got
definitely a pelvis.
Yes, yeah.
Yeah, I definitely don't know my anatomy of my foot as well as this. Yeah, so I'll do my best to keep the audio going. But what is the pelvic floor? You're talking about a group of muscles. So we're definitely not just a single muscle group in there. We're talking about a group of muscles running from the pubic bone at the front to the tailbone at the back, and also from each sit bone. And the pelvic floor also has two layers, so superficial, close to the outside, and deep within the pelvis. And the pelvic floor is very, like, literally fascially joined to the hip. So we see a lot of crossover between deep hip muscles, like obturator internus, and the pelvic floor. So that's, I guess, where is it? It's in the pelvis. And this is a bit of a 2D, again, you only see this if you've got the video going, of just all the different muscles that make up that pelvic floor muscle. So yeah, they are collectively called the levator ani, or ani. And then these are the more superficial ones that sit closer to the skin surface. Right. Okay. So the holes in the muscle tissue are for the passage of the tube from the bladder and the vagina for women, and the rectum. Yep. And we kind of call that the levator hiatus, which in Latin means hole. So we call levator ani muscles, and the hole in them is the levator hiatus.
Yeah. And
you can imagine with women, at least, the way that the pelvic floor has to stretch to allow a baby to come through here. So that's why.
Yeah. Is the biggest complication, like the change to the tissue physiology post birth?
Is that
like one of the biggest complications, like the change to the tissue itself, like the physiology of it?
Yeah. So from that stretch, do you mean?
Yeah. Yeah.
The answer is sometimes. Like, vaginal childbirth is the biggest risk factor for having a prolapse. But it's not that every single woman is going to have trauma to her pelvic floor muscles by having a baby.
Yeah.
There's an injury called a levator avulsion, which now will be the pelvic floor muscle pulling away from the pubic bone in here, and that tends to make that hole much larger.
Yeah.
And when you get that as an injury from childbirth, the effects of that is pretty intense, like pretty severe. And the other most sort of severe obstetric injury would be located at the perineum, which is we're talking closer to the skin surface, and that's the tears that women can get between vagina and anus as the baby's coming out. So, yeah, essentially, like some people can have a vaginal birth and have stretch to their pelvic floor, but the body and the hormones and the blood flow allow that to occur without trauma.
Yeah.
And yes, the muscle tissue does need to rest and recover and recoil.
Yeah.
But it does so quite well. Yes, the hiatus will remain larger than before they had a baby. That doesn't necessarily correlate with any sort of dysfunction. Whereas if they have a avulsion or a perineal tear, that's when we start to see pelvic floor dysfunction. So incontinence of bladder, bowel, prolapse, that sort of thing. That's when they come and see us.
For people listening to this that aren't clinicians, I mean, I guess and clinicians as well, like what would be the signs and symptoms when someone's like, I need to go and see a women's health physio?
Yeah. I got asked this question once by like a musculoskeletal physio that did a lot of weight training in his clinic.
Yeah.
And he was like, he was essentially saying like, well, won't they just tell me at the time if they're feeling a bulge in their vagina, for instance, and they have a prolapse? And I said, well, actually, like the most common symptom of prolapse doesn't occur at the time of exercise, but it will occur in the 24 hours afterwards. This heaviness and this feeling of something coming down.
Yeah.
And that was completely new to him, and he's been in the industry for ages.
Yeah.
So for him, he was like, crap, I can't just wait for them to tell me. I need to find out this information beforehand before I get them in the gym. So sorry, what was your question again? I go off on these tangents.
No, that was good. It was kind of like just it kind of leads into where, like, how people can, and I guess there would be two camps: the physiotherapist who perhaps doesn't have a lot of experience dealing with women's health, and especially as a male as well, sometimes it can be just harder to ask those questions. And then for some other practitioner, whether it be, and I'm stereotyping here, but I'm assuming, podiatrists may not know much about it, or even some GPs and doctors that listen to this as well, like, what kind of questions can you ask? Because as you said, it's not as easy as they'll just tell you what's happening, and you go, oh yeah, no, that's fine. You just need to go and see Hetty down the road. She'll help you out. Like, what kind of screening questions can we ask, and maybe signs and symptoms that may be kind of occurring when we're recommending general exercise or lifting and things like that, that like kind of bring your antennas up to say, no, you need to go and see women's health physio.
I know, like before I got into being a women's health physio, we always used to get told as physios to ask, your bladder and bowel question.
Yeah.
Probably more related to, I'm trying to think back to my neuro now, but, quarter equina, we're talking like saddle paresthesia and stuff like that. But I remember women would say to me when I asked, do you have any trouble controlling your bladder or bowel, or have you had any change in sensation or function? They would sometimes say, oh, like only if I jump on the trampoline or cough or whatever. So I found, for me personally, but again, I am a woman, that occasionally people would disclose leakage of urine in that moment. But I suppose for a male clinician, it's that added issue of for some women not feeling like that they're embarrassed to share that information. And so in that case, I know there's some clinics in their intake form, when they're kind of screening for what injury are you coming for, there'll be that tick box option if they had leakage or prolapse or whatever. Sometimes when I'm taking a medical history, asking about surgical history, especially if the woman's older, she might then tell you, oh, I've had a hysterectomy. And if you go a little bit further, she's like, oh, I had a uterus prolapse, or or I had endometriosis or whatever it is. And then you might be able to sort of say, oh, have you worked with a women's health physio? Do you have any concerns about your pelvic floor? Do you leak when you cough, sneeze, jump, that sort of thing? Does that answer that question?
Yeah, it does. I think it's important. I think of the similarity in musculoskeletal care, and probably just stereotyping, but I'm assuming for most males it can be hard. For me, it's a little bit easier because I've done it a couple of times, or more than a couple of times, but asking around people with bone stress injuries in females, do you have a regular menstrual cycle? And it used to be really difficult for me to ask that question, and now I'm quite confident asking and it kind of explaining the reason why. And I've had lots of times where I've sent someone to or referred them to a sports dietitian or a dietitian, and I think to myself, if I was too worried or a little bit scared to ask that question, I may not have been able to help that person all over. And I think it's similar with this as well.
Yeah, I think that's really, really good that you ask about the menstrual cycle, especially. It's said in the research, but for every woman that has incontinence, I think it's like over 65% won't actually disclose that to a health professional.
Yeah.
So I think that's where social media comes in handy, really, because it's something that people can look at in the privacy of their own home. They can see that there's help out there, there's treatment that they can get, and that more and more people are looking for it because they do want to. I hope, what I assume is they either are sick of washing all their clothes all the time from leakage, they're embarrassed, or that they want to be more physically active and that this is holding them back and they want to address it.
Yeah.
So I kind of hope for the latter too.
Yeah. Would you say like the pelvic floor exercise and therapy it's important for people who are doing like running and weights as much as just doing generalized strength training, even if they're not having any symptoms or issues? So for someone and I always think back to, because it's really quite public, which is awesome at the moment, some of our best marathon runners in the female field have all had a couple of children and then coming back and breaking records, and they're talking about like incontinence and how hard it's been and getting back to it. But some of them have gotten back in like 6 months to like Olympian level distance running, which is incredible. And they talk a lot about things that they went through postpartum and pregnancy. Would you say for someone that's is postpartum, it's not mandatory, but they should be doing some pelvic floor stuff? And then what does that kind of look like for you? And then how is that kind of assessed in the clinic?
Yeah. I was on a educational webinar thing with one of the leaders in our field called Taryn Hallam, and she got on and spoke about literally the latest research coming out in the International Continence, Foundation's bloody 7th edition book. It sort of said like, we don't need women to do pelvic floor exercises between 0 and 6 weeks postpartum. And I was like, what? Like, are you kidding me? Like, because I'd been telling women to, as soon as it was pain-free, to start doing their rehab after having babies, whether that was C-section or vaginal delivery. But so research does change a lot. But at the moment, according to that latest research, from 6 weeks, it's recommended that women start pelvic floor exercises. It's recommended that it's not mandatory, but it's strongly associated with reduced likelihood of pelvic floor dysfunction. It's, I think, becoming more commonplace that women will go and see a pelvic floor physio, women's health physio, at 6 weeks, and not just get the clearance from their doctor, who might not actually do an internal exam.
What does that look like in the sense of like, how are you, like, I'm thinking, say you're looking at someone's calf strength, you get them on the force plate and you have a look at kind of the difference between each side. I mean, how are you assessing kind of pelvic floor function, which I know function would be a very broad term, and then what does the rehab look like the advice and sets and reps and frequency with that, which I know is a broad question as well. It's individualized.
It is, but like the assessment can be different for everyone. It's obviously a very private and sometimes difficult area for people to have assessed, whether they've had trauma in the past, so like sexual abuse, that type of thing. So not necessarily does the assessment have to include an internal digital assessment, so with 1 or 2 fingers inside the vagina to assess the pelvic floor muscles, to assess their tone, to assess how much they can squeeze and lift and whether they can relax, etc. So we can look at the pelvic floor with an ultrasound. So the transducer head's placed on the perineum here. And we can, really quite accurately have a look at someone's ability to contract and relax their pelvic floor, and as well as what happens when they push down, cough, etc. So that's really quite a good assessment technique, and it's non-invasive, more or less. And then if that's still too much, we can do a transabdominal. So the transducer goes across the lower belly here, or we can do a visual assessment. If someone's happy to take their underwear off, we can have a look at the skin and the tissue, from whether it's moving in the correct directions and stuff like that. And obviously the assessments start to get less accurate the more we can't get hands-on. But there's certainly options for people if they're a bit concerned straight away to maybe have an assessment, if that makes sense.
Yeah. And then after, if you have identified something or someone has, it's struggling with that, what does the rehab look like, and that journey back to 100%?
Yeah. So I guess when I first came into pelvic floor physio, I thought everyone just needed strengthening, We just kind of got in there. We've got to get in there and get them using their pelvic floor and strengthen it all up. And, how simple is this? 3 sets, 10 reps.
Every second day. Yeah.
Great. Everyone just needs to get to that and they won't have any issues. And then, that was probably, how many years ago? Like 5 to 6, I think, years ago, since I had that simplistic view of my job. And now it's just like, there's so much more to it, including a lot of athletes needing actually down training. So they need to learn to lengthen their pelvic floor before they can actually do strengthening exercises. Yeah. So the treatment does vary depending on what we find. So people can be tight and weak in that chronically held state. So we might actually do down training first. And that can be just biofeedback. So like coach, therapist to patient, and then they do their breathing and their relaxation exercises at home. We reassess and versus someone that is really weak and they do just need to strengthen, and then they get an individualized program of squeezing and lifting their pelvic floor muscles and holding for time. Yeah. And also doing quicker movements, versus biofeedback devices. So a bit old school, but using machines like this with a vaginal probe. This can be, them being able to see on the screen when they're contracting and when they're relaxing, so to help with like timing and that sort of stuff. You can also get similar machines, but with electrical stimulation. So it's e-stim for the muscles, getting them to then contract with that. So lots of different treatment options.
Does that, once you have gotten to the point like that you're happy with it, is that a long-term change, or is this something that people need to do consistently, weekly, twice a week, or they come back in and they see you annually to see how they're going and see if there's any change? What does that look like?
Yeah, there's so much argument in the pelvic floor space at the moment around like, why are we training the pelvic floor muscles every day? And surely, if we're training someone's muscles to fatigue, they should be, why isn't it like other skeletal muscles where there's rest days? Yeah. And there's like heaps of debate over this, there's kind of 2 camps. Like some people saying like, yeah, we're not pushing them hard enough. They're just doing, X amount of reps every day, but they're not overloading the muscle tissue. So there's a bit of debate at the moment, but essentially all we know for certain is that we want 12 to 16 weeks of regular individualized pelvic floor muscle training, where the muscles should be challenged further and further, whether that's with seconds that the person's holding that contraction for, or reps that they're doing, or positions that they're doing them in. So the easiest being like lying on your side, to then standing upright, to then coordinating it with a deadlift, that type of thing. So we want to progressively challenge the pelvic floor more and more over that 12 to 16 weeks. And then the research basically says once you get your pelvic floor conditioned to that point, you can then maintain